miscellaneous bacteria. Under miscellaneous bacteria, first one is a gram-positive bacteria, in that Listeria monocytogenes. It is a foodborne zoonotic pathogen. Mainly, it will cause serious infections in human. Mainly, the infection is seen more commonly in neonates, pregnant women, and elderly people. Pathogenicity of Listeria monocytogenes. It will grow only in the refrigerated food and it will tolerate preserving agent. The mode of transmission is most commonly through contaminated food. Raw milk is the most common transmission, followed by vertical transmission from mother to fetus. Transmission is there in Listeria monocytogenes. Intracellular survival. It is a facultative intracellular organism. Survival inside the host cell is due to incubation and lysis of phagosome by forming spores, which is mediated by listerolysine O. Direct cell to cell spread is due to host cell actin polymerization, which is mediated by listeriopods. Next one is a clinical manifestation of Listeria monocytogenes. Infection in pregnancy before 20 weeks, it is very rare and it will lead to abortion, stillbirth. In neonatal disease, it will cause two types. One is early onset and the other one is the late onset. Next one is the difference between early onset disease and late onset disease. It will occur less than 5 days of birth, and in late it will occur more than 5 days of birth. And early is occurred from maternal genital flora, late is occurred from environment. Early is associated with obstetrical complication. In late, it is not associated with any complication. In early, the most common form is neonatal sepsis is seen. In late, neonatal meningitis is seen. In early, granulomatosis infantis septica will occur very rarely. In neonatal granulomatosis, infantis septica will not be seen. The mortality rate is less than 30% in neonatal. The mortality rate is higher than 10% in late, and in early it will not cause nosocomial outbreaks. In late it will cause nosocomial outbreaks. In adult, it is associated with steroid therapy, HIV, diabetes mellitus, and malignancy. And bacteremia, it will cause meningitis. Most common cause of meningitis is seen in kidney transplanted patient. After 1 month, it is seen. It will also cause gastroenteritis after contaminated milk, meat, and salad. Next one is a lab diagnosis of Listeria monocytogenes. It is a gram-positive coccobacilli and it is a catalyzed positive and it will show tumbling type of motility. Nosocomial outbreaks are seen. It is the most common. It is motile at 25 degrees Celsius and it is non-motile at 37 degrees Celsius, and growth will improve if cultured in thioglycol broth at 44 degrees Celsius, which is very cold enrichment broth. Media used are blood agar, chocolate agar, and an instillation to rabbit eye, which will cause conjunctivitis in rabbits. Actinomyces is a gram-positive branching filamentous bacteria. Human pathogenic actinomyces are Actinomyces, Streptomyces, Nocardia, and Actinomyces. All these species will cause disease in humans. Actinomyces is non-acid fast and anaerobic. Nocardia is aerobe and acid fast, which is 1% sulfuric acid. Streptomyces and Actinomyces are aerobes and it is non-acid fast and it will cause actinomycetoma in humans. Differentiating between actinomyces and nocardia. Actinomyces is non-acid fast and nocardia is partially acid fast. Oxygen requirement is anaerobe in actinomyces. In nocardia, it is obligate anaerobe. Sugar fermenter in actinomyces and in nocardia, it will utilize sugar oxidatively. In actinomyces, the habitat is more commonly seen in oral. Infection will occur endogenously. In nocardia, more usual habitat is seen in soil. Infection will occur exogenously. The risk factor for actinomyces is disease occur in immunocompetent cause. In nocardia, usually it will affect people with low immunity. In clinical form of actinomyces, it will affect the cervicofacial, abdominal, and other forms. In nocardia, clinical forms are pulmonary, CNS, and actinomycetoma. Actinomyces granules or sulfur granules are present, which are hard, non-emulsifiable, and it consists of branching filamentous bacilli, and it is surrounded by clubs, and it will show sun-ray appearance. And in nocardia, granules are soft and lobulated. Commonly, it is found in mycetoma. It is rare in other conditions. Culture of actinomyces is spidery molar teeth colony in solid media, fluffy ball at bottom of the liquid medium. In nocardia, it is cultured by colonies of creamy, wrinkled, and orange to pink color is seen. Recovery is done by selective media, paraffin bait technique, Levanson Jensen medium. Through this way, it is cultured. Next one is the Toparima vipale. It is a gram-positive actinomycet. It is not closely related to any known genus. Mainly, it will cause Whipple's disease. Whipple's disease mainly it will affect the small intestine of human. In Whipple's disease, the most common symptom is fever, abdominal pain, diarrhea, weight loss, and migratory polyarthralgia will be there. Mesenteric lymph node or small intestine are primarily involved in Whipple's disease. Laboratory diagnosis, histopathological staining of biopsy, intestinal biopsy. It will show vacuoles within the macrophage staining, PAS stain positive bacilli. Culture of Treponema vipale, it is unsuccessful. PCR targeting 16S RNA, it is done to identify the bacilli. Next one is the erythropelothorax rasiopathiae. It is a gram-positive bacilli and it is a catalyzed negative and hydrogen sulfide is positive. In erythropelothorax rasiopathiae, it will causes erysipeloid skin lesion and it is violet, which means violet color lesions will appear in which swelling with severe pain, but no pus will be seen. The most common site is finger, which is also called a seal finger and whale finger. Next one is the miscellaneous gram-negative bacteria, Campylobacter. It is a micro-aerophilic curved gram-negative bacilli. They are zoonotic infection which occur from animals and it will cause both diarrheal Campylobacter jejuni and systemic disease is caused by this species Campylobacter fetus. Next one is the epidemiology. Mode of transmission is mainly by ingestion of raw uncooked food. Poultry is the most common. Raw unpasteurized milk or water through direct contact with animals. Oral anal sexual contact. Some Campylobacter triggers are Guillain-Barre syndrome will be there. Mainly it is caused by Campylobacter jejuni serotop O19 and it is a chain disease. Most commonly age affected are Campylobacter jejuni. It will affect most commonly in children. Campylobacter fetus. It will affect extremes of ages. Developing versus developed countries. In developing countries, Campylobacter is hyperendemic. In developing countries, mostly it is asymptomatic, except less than 2 years it is symptomatic. In developed countries, Campylobacter is a leading bacterial cause of diarrheal disease. Seasonality, Campylobacter incident peaks during summer and early autumn. It is seen. Next one is the pathogenesis of Campylobacter. Motility of strain. It will possess polar flagellum and it will exhibit darting motility and it has the capacity to adhere to host tissue and in which the toxins will play only a minor role. Enterotoxin, which is heat labile, which is similar to cholera toxin. cytotoxin, cytolethal distending toxin or CDT. Next one is a proteinase capsule-like structure, S layer, which is expressed by Campylobacter fetus. Next one is the clinical manifestation of Campylobacter. Mainly intestinal infection is seen, inflammatory diarrhea, abdominal pain, fever, and rarely bloody stool is seen are the most important clinical manifestation of Campylobacter. Some extra-intestinal infection is mainly due to Campylobacter fetus, which will develop most commonly in immunocompromised cause and at the extremes of age it is seen. In persons with HLA-B27, reactive arthritis and other rheumatological manifestation is seen. Campylobacter triggers, it will cause Guillain-Barre syndrome. Mainly it is caused by Campylobacter jejuni serotype O19 and it is a chain disease. Laboratory diagnosis of Campylobacter, gram staining a smear of fecus may it will show gram-negative bacilli and it will appear like comma-like appearance, just like Vibrio, and S shape or spiral, which is known as gull wing shape. Under dark ground microscopy, it will demonstrate a darting motility of the bacilli. The bacilli will move like darting in movement. Next one is the culture media. Transport media such as carry Blair media is used. Selective media such as Kiros, Butzless, and Campay blood agar plate selective media is used. Culture conditions micro aerophilic 5% oxygen and thermophilic. It will grow at 42 degrees Celsius except Campylobacter fetus. It is non thermophilic. Next one is the Helicobacter. Helicobacter is a curved gram-negative rod. It will colonize the stomach and it will cause peptic ulcer disease and gastric carcinoma. First one is the pathogenesis of H. pylori. Colonization. First H. pylori will colonize 50% of world human population, 30% in developed countries, and nearly 80% in developing countries. Adhesins, few 2% strain bind to mucosal epithelial by expressing blood group antigen binding adhesion that will bind to Lewis blood group antigen. Adherence is associated with lipoprotein and it will induce the pathological changes by producing toxin. One is the vacuolating cytotoxin. It will induce the formation of vacuoles in the cytoplasm of epithelial cell. Other one is the cytotoxin. It is associated with gene A. Molecular mimicry will occur. Lipopolysaccharide of H. pylori will cross-react with Lewis blood group antigen and it will contribute the pathogenesis of chronic active gastritis. Some environmental risk factors are smoking will increase the risk factor for causing ulcers and cancers in H. pylori colonized individual. High diet such as salt and preserved food will increase cancer risk. Antioxidants and vitamin C are very protective for H. pylori infection. The clinical manifestation of H. pylori is mostly it will cause acute gastritis in which antrum part of is the most common site involved. Cardiac end is not involved. In antral gastritis, it will predispose to duodenal ulcers and pangastritis will be there. It will predispose to adenocarcinoma of stomach. Next one is say it will cause peptic ulcer disease. 80% of duodenal ulcer and 60% it will cause gastric ulcer due to H. pylori and it will cause chronic atrophic gastritis, autoimmune gastritis and it will promote pernicious anemia, adenocarcinoma of stomach, non-Hodgkin's gastric lymphoma is caused by H. pylori. Next one is the protective role of H. pylori. Colonization of H. pylori. It has an inverse relation with occurrence of gastroesophageal reflux disease, Barrett's esophagus, adenocarcinoma of esophagus, and asthma. Next one is a laboratory diagnosis. invasive test is done. Endoscopic guided multiple biopsies is taken from gastric mucosa. Mostly the biopsy should be collected from antrum and corpus region, and it is subjected to histopathology with Watson stary silver staining is used. Next one is a microbiological method. Under gram staining, it will look like curved gram negative bacilli with a seagull shaped morphology. Culture media used for H. pylori is it is the most specific test and it is not sensitive. Biochemical test, oxidase, catalase, and urease test is positive for H. pylori. Biopsy urease test, it is a very rapid urease test and it will detect urease activity in gastric biopsy. And biopsy urease test is very rapid, sensitive, and it is one of the very cheap method. Some non-invasive test is used to diagnose H. pylori. Urea breath test. It is very popular because it is non-invasive and it is one of the accurate tests, very quick and simple, and it is the most sensitive. It is used for monitoring the treatment after improvement. Once it become negative, it is used. Next, stool antigen, antigen assay. It is used for monitoring of treatment and screening of children. The stool antigen assay is used. Antibody immunoglobulin G detection of ELISA. It is used for screening before endoscopy and seroepidemiological study. It is used. Next one is the Legionella. It is a fastidious gram-negative short rod and it is associated with two respiratory syndromes. One is Pontiac fever and the other one is the Legionnaires disease. In most cases, it is associated with serogroup 1 and which is followed by serogroup 4 and 6. Some very rare species will affect human infection, such as Legionella mycardade, Pittsburgh pneumonia agent, which is acid fast, and Legionella longbicare. Next one is the reservoir of Legionella. Mostly, it will inhibit the aquatic bodies, natural water sources such as river or even inside amoebae. Artificial aquatic sources such as air conditioner is the most reservoir of Legionella. Transmission of Legionella mostly it is transmitted by aspiration is the most common mode through oropharyngeal colonization or through direct drinking of contaminated water. It can be spread from aerosols from contaminated air conditioner nebulizer and humidifiers. Through this way it is transmitted. Direct installation into lungs during respiratory tract manipulation. In Legionella, there is no human to human transmission. There is no animal reservoir and no carrier. Pathogenesis of Legionella. Legionella will enter the lungs through aspiration or direct inhalation and it will cause attachment and invasion to respiratory mucosa and coiling of phagocytosis will occur. Macrophage phagocytose Legionella by a coiling mechanism. It will evade the intracellular killing and it will inhibit the phagosome lysosome fusion. Next one is the clinical manifestation of Legionella. Mainly, it will cause Pontiac fever. It is an acute flu-like illness. Other one is the Legionnaires disease. It is also known as pneumonia. It is a type of interstitial atypical pneumonia. It is the fourth common cause of community acquired pneumonia. It will occur only in 2 to 9% of cases. It is responsible for 10 to 50% cases of nosocomial pneumonia. Mostly for the hospital outbreak, the serogroup 6 is commonly involved. Some extrapulmonary legionellosis. The most common extrapulmonary site is and prosthetic valve endocarditis affection will be there. Other manifestations such as sinusitis, peritonitis, pyelonephritis, skin and soft tissue infection is seen in Legionella. Laboratory diagnosis of Legionella is In gram stain, it will reveal numerous neutrophil in which no organism will be there because it is weakly stained, so organism will not be there. Under direct fluorescent antibody diagnosis is made. For culture, buffer charcoal is tetragon, which is the main recommended media. Antibody detection, it is useful only for the epidemiological purpose. Urinary antigen is diagnosis is done. Urinary antigen is very rapid and it is a cheaper and easy to perform. It will remain positive even after antibiotics. Next to culture, urinary antigen is a highly sensitive and specific method. PCR is also useful for isolation from environmental water spread. Next one is the Calmetobacterium granulomatosis. It is the agent of granuloma inguinale. The other name for granuloma inguinale is granuloma venerum or dona venosus, but the present name is Klebsiella granulomatis. The clinical features of granuloma venerum is in which the painless ulcer is seen. Ulcer is granulomatous, which will appear like beefy red ulcer which will bleeds very easily, in which no lymphadenopathy enlargement is seen, but pseudopubis is seen of rat bite and fever, which will inhabit on aquatic bodies. Donovan bodies, which is stained by white Gemsa stain in large cyst-like macrophages filled with deeply stained capsular bacilli, and it will appear like a safety pin-like appearance, bipolar, and culture is by embryonated hen set and on HEP2 cell line. Through this way, granuloma venerum is cultured. Next one is a rat bite fever. The agents of rat bite fever is Streptobacillus moniliformis and Spirillum minus. Streptobacillary rat bite fever, the agent is Streptobacillus moniliformis, and it will cause disease such as Havelet fever, which is mostly seen in USA, which is also called as Erythema andreaticum epidemicum. Next one is the spirally rat bite fever. The agent of spirally rat bite fever is Spirillum minus, and it will cause disease such as Sodoku, which is more commonly seen in Japan. Next one is the differentiation between streptobacillary rat bite fever and spirally rat bite fever. The incubation period of streptobacillary rat bite fever is 7 to 10 days. Clinically, it will cause septic fever, rashes, painful polyarthritis, and in streptobacillary rat bite fever, frequent relapses is seen. The laboratory diagnosis is gram-negative pleomorphic bacilli in shade with beaded or with fusiform swellings will be seen, which is non-motile and readily it will develop like L form. In culture, it will grow on media such as egg yolk, serum protein or starch. Under artificial media, it is cultivable. Next one is the spirally rat bite fever. The incubation period is 1 to 3 weeks. Clinical feature is same like the streptobacillary rat fever. Along with that, a lymph node enlargement will be there. But in streptobacillary rat bite fever, lymph node enlargement will not be there. Next one is a lab diagnosis of spirillary rat bite fever. It is gram-negative spirally coiled bacilli, motile, ambidextrous flagella. It is not cultured on artificial media and it can be isolated from guinea pigs or mice. In artificial media, it is not non-cultivable. Next one is the Gardnerella vaginalis. Gardnerella vaginalis will cause bacterial vaginosis. It is a gram variable. Mostly it is a gram negative and it will have metachromatic granules. Other organisms also implicated such as Mycoplasma hominis, Moblinicus prevotella, Ureaplasma and Peptostreptococcus are also implicated in bacterial vaginosis. Based on Amsel's criteria, the bacterial vaginosis is diagnosed in which the four criteria is present. First one is a profuse, thin, low viscous, white homogeneous vaginal discharge is seen. The pH of vaginal discharge in bacterial vaginosis should be greater than 4.5. Due to decrease in concentration of lactobacilli, the vaginal discharge concentration will be increased. Next one is a fishy odor associated by vaginal secretion, which is mixed with a 10% solution of potassium hydroxide, which is known as Swift test. In bacterial vaginosis, Swift test is positive. Clue cells, vaginal epithelial cells is coated with coccobacilli. Next one is a Nugent score. It is used to count number of Gardnerella vaginalis, Mobilinicus and Lactobacilli in the gram-stained smear of vaginal discharge. A score of greater than 7 is diagnostic of bacterial vaginosis. Next one is the Pasteurella maltosida. It is the most common organism in human wound. Mostly it is inflicted by bites of cats and dogs. Mostly it will cause wound infection in which regional lymphadenopathy and respiratory infection is seen. In Pasteurella, the laboratory diagnosis is it is non-motile gram-negative coccobacilli with bipolar staining, and it will resemble just like the Yersinia, but it will differ from the following features, and it is oxidase positive and indole positive, but in Yersinia it is oxidase and indole negative, and it will failure to grow on McConkie agar. Next one is the Francella tularensis or tularemia. It is transmitted by direct contact with rodents, tick bite, inhalation, and ingestion. Subspecies are Francellaria tularensis. It will has 4 subspecies: Tularensis holaritica, novicida, and mediacitica. The first 3 are found in North America, and subspecies mediaciatica is found in Central Asia. Subspecies is the most common and most prevalent among the all other species. Next one is a clinical manifestation of tularemia. Mostly it will cause many clinical syndrome. First one is the ulceroglandular tularemia, which is the most common form of tularemia, in which ulcerative lesion at the site of inoculation with including regional lymphadenopathy is seen, and pulmonary tularemia is seen. Oropharyngeal tularemia and lemming fever, which is seen in Norway. Oculoglandular tularemia is seen. Typhoid-like illness, agent of bioterrorism, which is under class A. Next one is a laboratory diagnosis of tularemia. It is small, gram-negative coccobacillus and with bipolar appearance, non-motile and capsulated and filaments, and it is filterable, fastidious, and obligate anaerobe. The media used are Francis blood dextrosustane agar. Antibody detection is the main important diagnosis of tularemia. Next one is the Chromobacterium violaceum. It is a saprophyte. Mostly it is found in water and soil. Mostly it is seen in tropic region, and it will cause skin lesion, and it will appear like violet color in appearance. So the name violaceum is described, and it will cause sepsis and liver abscess. It is motile, gram-negative, facultative, anaerobe, non-sporing, and coccobacillus, and it will produce violet color, non-diffusible pigment called violacin. Next one is the Capnocytophaga species. Several species of Capnocytophaga ocraceae, Capnocytophaga gingivalis, putigania have been a part of human mouth flora. It will occasionally cause periodontal disease and sepsis, which is more commonly seen in immunocompromised horses. Mostly it will affect the mouth. Species such as Capnophora canimorsus and Cyanodegme. It is the common cell seen in mouth of dogs. Mostly it is transmitted by dog bites. Laboratory diagnosis. They are fusiform, filamentous, gram-negative coccobacilli, highly fastidious, and it will require carbon dioxide for growth, and it will produce yellow-orange pigment, and it do not have flagella, but it has a gliding movement on agar surface.